All right, in this course, we will be discussing cardiac arrest and shock. So this presentation will cover the core competencies required for the EMTs and EMRs in the 2025 NREMT recertification. So it's going to be focusing on the management of cardiac arrest, including pathophysiology, treatment techniques, and post-resuscitation care. So this will be a comprehensive overview, including both adult and pediatric considerations. With that being said, I always want you to remember that you need to follow your local protocols. So if you are not with the medical director that I use and your protocols are a little bit different, you always make sure you are following your own local protocols. All right, so for the introduction into cardiac arrest and shock. Cardiac arrest is the sudden cessation of effective heart activity, and shock as the state where the body's organs do not receive adequate blood flow. So while shock and cardiac arrest are distinct conditions, they are often linked together. So patients in cardiac arrest are in shock, and treating one can actually help the other. So the role of you as pre-hospital EMTs, EMRs, and so forth is to ensure survival through immediate interventions. So the focus of this presentation is going to be CPR, pharmacology, which I know most EMRs and EMTs cannot administer cardiac epinephrine. However, we are going to discuss it because if you do have to call in an ALS crew or a helicopter or whatever, it's always good for you guys to know and understand this. It also is going to go through the rhythms, infection control, and then the pediatric differences. All right, pathophysiology of cardiac arrest. So the fundamental mechanism behind cardiac arrest is the heart's failure to pump blood effectively. So that's leading to the cessation of circulation. Some common causes are going to be heart disease or arrhythmias like ventricular fibrillation or ventricular tachycardia. Some secondary causes can be hypoxia, trauma, or drug overdoses. It is very important to recognize cardiac arrest early to improve those outcomes. With that, the cascade of events that can occur once cardiac arrest happens, like the hypoxia, the acidosis, or even organ failure. So a question that you should ask is what might happen if CPR is delayed for several minutes? So let's discuss that. If CPR is delayed for several minutes, it can have a serious consequence as the brain and other vital organs depend on a continuous supply of oxygen-rich blood to function properly. So here's what might happen. First, brain damage can occur just after 4 to 6 minutes without oxygen. The brain cells then begin to die. The longer the delay in the CPR, the greater the risk of permanent brain damage or even brain death. Next is cardiac arrest. So without that immediate intervention, the heart remains in a state of arrest, meaning it cannot pump blood to those vital organs. So if CPR is not started soon enough, the chance of reviving that person decreases. So with lower survival rates, studies have actually shown that for every minute that CPR is delayed, the chance of survival decreases by about 10%. So the delay of several minutes significantly lowers that likelihood of a positive outcome. And next is organ damage. Other organs such as kidneys and liver, they also depend on that oxygenated blood. So prolonged lack of blood flow can essentially lead to organ failure. So in summary, delaying CPR for several minutes can actually drastically reduce the chance of survival and increase the likelihood of a long-term damage to the brain and other organs as a whole. So really, immediate action is very, very crucial for this patient's survival. Pre-hospital CPR quality. So the essential elements of high-quality CPR are your compression depth. So at least 2 inches for adults with a compression rate of 100 to 120 per minute. You want to be sure there is full chest recoil to allow the heart to refill. Minimizing interruptions in compressions is very important. So high quality CPR improves that coronary and cerebral perfusion, which directly impacts the likelihood of survival. If you have poor quality CPR, that's going to include shallow compressions or possibly even quite a few interruptions, which then again can reduce that survival rate. So a question is, what challenges do EMTs face when performing quality CPR in the field? Now remember, some of us are in very rural areas where you only might have one, maybe two responders. So what different challenges do you face? So EMTs face several challenges when performing quality CPR in the field. These can range from environmental factors to physical limitations. So some key challenges that you might encounter are: one, limited space. In many situations, such as cramped homes, crowded public spaces, moving vehicles, possibly like in the back of an ambulance, the EMTs may not have enough room to perform CPR effectively. Lack of space can make it difficult to position themselves properly and apply the necessary chest compressions and ventilation. Next is patient positioning. The way that the patient is positioned can actually affect the ability to perform high quality CPR. So if the patient is lying on uneven surfaces, maybe a bed or on the ground, or in an awkward position of any sort, it can be challenging to maintain that proper hand placement and compression depth. Next is fatigue. So CPR, especially when performed for an extended period of time, can be physically exhausting. So you as pre-hospital may experience that fatigue, which then can impact the effectiveness of chest compressions, potentially leading to shallow compressions or inconsistent compressions. This is why having more team members available to take turns is very important. Another one can be the inconsistency of compression depth. So for CPR to be effective, chest compressions need to be at least 2 inches the depth of the chest at a rate of 100 to 120 compressions per minute. So it is difficult to maintain that depth, especially if you are getting fatigued or working under less than ideal conditions, like moving the patient or performing CPR while in motion or using suboptimal tools. Maybe there's a lot of people around, you're in a public area, there's family screaming in the background, and so forth. Then you have environmental factors like external conditions like maybe poor lighting or cold temperatures, noises, or even extreme weather can make it difficult for EMTs to focus and perform CPR correctly. So these conditions may also make it the hardest to assess the patient's condition and monitor the changes during that resuscitation. Some obstacles that you might run into with the airway management, though, is securing that airway and being particularly challenging, especially if that patient has a blocked airway, maybe they've got vomit or other obstructions in there. So in addition, it can be harder to effectively ventilate that patient if they are in a difficult position or maybe they have facial injuries. Some other problems could be lack of immediate access to advanced tools. So while you're pre-hospital in a basic life support aspect, CPR can be more difficult, meaning you might not have more advanced tools like the defibrillators or maybe a Lucas CPR machine. Maybe you don't have the medications that are often required. And so now you're doing CPR on your own physically rather than having a Lucas CPR machine. Maybe you don't have the cardiac epinephrine that you're allowed to give. So you may be waiting 20 minutes, 30 minutes, 45 minutes for an ALS service or a helicopter to arrive on scene. Another problem that can come about is crowd control and distractions. So in public spaces, EMTs, EMRs may face the distractions of bystanders who may not know how to help or may interfere with the resuscitation efforts. So this can add stress and prevent EMTs and EMRs from focusing entirely on the patient. Next is that time pressure. So you may work under immense time pressure where every minute counts in cases of cardiac arrest, and the need to transport that patient quickly to the hospital while continuing CPR can complicate matters, especially if you're a rescue squad that is 30, 45 minutes from an ALS service or a transporting BLS service or so forth. So some patients may have underlying medical conditions. Maybe it's obesity. Maybe you can't get that patient into a regular truck. Maybe you have to wait for a bariatric truck. Or maybe there's only 2 of you on scene and that patient is too heavy for you to safely pick up and transport on your own. Or maybe there's trauma that can complicate CPR. So think about it this way. For CPR in an obese patient, it might require more force or repositioning, and patients with broken ribs or other injuries may experience additional pain or complications during chest compressions. Again, we've always talked about that if you don't have a patient's airway or pulse, you don't have a patient, so it really doesn't matter. However, being obese, being in an awkward position can complicate things for sure. Excuse me. So these challenges make it clear that performing quality CPR in the field is a highly demanding task that requires EMTs, EMRs, paramedics, pre-hospital workers as a whole to be skilled, adaptable, and resourceful. So treatment of cardiac arrest with a BLS only crew. So you need to make sure that you're focusing on those immediate actions and take to initiate the resuscitation, starting with chest compressions. Next, you want to try to use an AED and provide ventilations. But remember, if you're not trained on something, you should not be doing it. So chest compressions, breaths, and using an AED. So timely recognition from a bystander standpoint or a family standpoint is very important because that will get that activation of EMS, which is pretty key in initiating that resuscitation process. So remember, early defibrillation in shockable rhythms is key. So the shockable rhythms are going to be your ventricular tachycardia, but remember those people can be alert and they can have a pulse. So again, remembering that AEDs do not go on unless the patient is unresponsive. And then the other one is ventricular fibrillation, which is the bottom part of that heart quivering. They are unresponsive and they do not have a pulse with that rhythm. So even without an advanced airway management or medications, remembering that high quality CPR and early defibrillation can significantly improve the chance of survival. So how can you ensure that you perform high quality BLS under pressure when you do not have an ALS crew or a advanced helicopter crew readily available to you? Maybe you have to wait 30, 45 minutes in some of these rural areas. So EMTs and EMRs can perform high quality BLS even under pressure by focusing on key strategies. First is practice. Practicing regular trainings, knowing and understanding how to do chest compressions. Maybe you're going to be using simulation or drills, participating in realistic high pressure simulations where you're actually performing CPR, but it's in a more chaotic simulation type drills. Maybe it's knowing your ratios and maintaining that proper 30-2 compression ventilation. Efficient teamwork, that is key. However, I know in some of these smaller services or rescue squads that are volunteer, you may not have a team to work with. It might just be you. So making sure that when you do have a team that you know how to communicate, it's being done properly and efficiently. Next is making sure that you are rotating. If you do have 2 people rotate in and out, even if it's not every 2 minutes, maybe it's a minute, maybe it's 3 minutes, depending on the person that is doing the compressions. And then with your compression techniques, you want to make sure that your depth is at least 2 inches deep, and it's very critical to make sure that you're bringing your hands all the way up and off the chest to refill that heart and then to start compressing again. So your compression ratio should maintain that rate of 100 to 120 compressions per minute. Making sure that your environment, making sure that you have control of your environment and that it's clear and that you have clear communications and so forth.
a lot of times you know, especially in public areas, you may have a crowd. How are you going to control that crowd if it's only you, or maybe you and a partner? You got a person in cardiac arrest, you need somebody doing compressions, you need somebody doing breaths, and now you got a crowd issue. How are you going to control that if in a public area and you don't have anybody else there and readily available to help you? You know, when do you get that AD? If it's only you, when do you go grab the AD versus when are you you know, just doing compressions? And then remember, beforehand you want to make sure that you have your airway management tools readily available. You know where they're at in your bags. You're consistent. You know that in a high stress situation, if you're called out to a cardiac arrest, you need to know, I need to bring in bag A, B, and C. And then your mental resilience, making sure that you are focused and not focused to the point to where you are like tunnel vision, but that you have that mental resilience that you can manage yourself and a team in those high pressure situations. And then patient factors. Maybe the EMT should adapt to the patient specific factors, like maybe they have airway issues, maybe they have a tough airway. So there's a lot of different things that come into it. Field considerations in less than ideal conditions. You're maybe in a vehicle, you're maybe in crowded spaces, uneven ground, maybe you're in a bathroom, you know, stuck between the toilet and the bathtub, and there's only one person able to get in, and you're a smaller person and you can't get that person out by yourself. Maybe you're in the middle of a, you know, crowd of some sort, and there's people yelling at you and telling you to do this and telling you, I'm a nurse and I'm a doctor and I'm a this and I'm a that, and that chaos around you is just becoming so overwhelming. So know how to control your own self, but also making sure that you can control the crowd as well. So big thing there is staying physically fit, making sure that you're mentally prepared, whatever else, and then just integrating different strategies that you can ensure that you perform high quality CPR even under pressure, and giving those patients the best chance for survival. So the pharmacological action of epinephrine in cardiac arrest. So remember, epinephrine is a critical medication used in cardiac arrest. I know it at least in our protocols, it is not there for BLS. However, I think it's very important that you guys know this and understand it. So its mechanism of action is a vasoconstriction, which improves perfusion to those vital organs like the heart and the brain. So it increases that heart rate and the myocardial contractility, supporting that blood flow. So the standard dosing for adult patients is 1 milligram every 3 to 5 minutes during resuscitation, and the timing of administration for that epinephrine should be given in conjunction with high quality CPR, but it's not a substitute for CPR. Some people say, oh, you can give epi and you don't have to do chest compressions. That is completely untrue. You need to do both, okay? Medication's not going to take the place of CPR. So why is it essential to wait that 3 to 5 minutes before administering another dose of epi? So again, when an ALS service gets out there, they may ask you to write the time down and keep track of the time that they give the first dose of epi or the second dose of epi, and it's because they want to wait that 3 to 5 minutes before administering another dose. So it is essential to wait because before you administer another dose, because the epi in the cases of cardiac arrest or other emergencies like anaphylaxis, but we're talking cardiac arrest, are due to several important reasons related to the drug's effects, the safety, and the body's response. So epinephrine's half-life and duration of action, it starts out, it's relatively short half-life, meaning it does not stay in the body for long after it's being administered. So after it's injected, it quickly begins to work, stimulating that heart, increasing that blood pressure, and improving blood flow to the vital organs. But the effects of the epinephrine generally last for 3 to 5 minutes, which is why it's important to wait before giving that second dose. So giving another dose too soon can actually cause an overdose of excessive stimulation of the heart and the blood vessels, leading to those dangerous side effects. Is there a risk of overdose? Yeah, there can be. So you can have the risk of overdose and tachycardia. So remember that epinephrine is a powerful stimulant of the heart, and administering too much or too frequently can actually cause tachycardia. Or an arrhythmia or irregular heartbeats or whatever. So this can actually increase the risk of complications like cardiac ischemia, and which is, what is cardiac ischemia? That's when that is reduced blood flow to the heart, or myocardial infarction, which that's what is considered a heart attack. So by waiting that 3 to 5 minutes between doses, the body actually has time to adjust to the effects of the initial dose and prevent the risk of an overdose. Next is allowing time for evaluation. That 3 to 5 minute interval provides time for evaluation of the patient's response in that initial dose of epinephrine. So, for example, in cardiac arrest, it allows the medical team to assess whether the heart has started to respond. For instance, a return of spontaneous circulation or so forth. Or if the condition has improved enough to delay further dosing. So this interval also allows for the time to assess the need for additional interventions like chest compressions, defibrillation, maybe it's other medication. It's a lot of the times based on that patient's condition. So you want to maximize the effectiveness. So giving epi at the appropriate intervals maximizes its ability to help restart the heart or support that circulation during resuscitation efforts. So the purpose of waiting that 3 to 5 minutes is to allow those effects of the first dose to wear off before administering a second dose, which helps then ensure that it will have the maximum benefit when given. You also want to avoid excessive vasoconstriction. So remember, epi causes vasoconstriction, which helps to what? Increase that blood pressure and to direct blood flow to vital organs. So, however, if too much epinephrine is given too quickly, it could lead to excessive vasoconstriction, reducing that blood flow to less vital areas like the extremities. So an increasing the risk of complications such as tissue damage or maybe ischemia. So essentially, long story short, because I like to talk a lot, waiting that 3 to 5 minutes before administering another dose of epi ensures that the drug has time to exert its effects without causing harmful side effects like an overdose, arrhythmias, or that excessive vasoconstriction. It also gives the medical team time to assess the patient response and to adjust the treatments as necessary, ultimately improving the chance of a successful outcome. So again, I know and I understand that BLS crews cannot give epi in a cardiac arrest situation, but I think it's very important for you guys to know and understand what epinephrine does to the body. Next is the role of capnography in cardiac resuscitation. So capnography is the monitoring of exhaled CO levels during the resuscitation. So the EtCO2, which is the end-tidal carbon dioxide, can be used to assess the effectiveness of CPR. Low EtCO2 suggests ineffective chest compressions or the need for reassessment. So sudden increase in the EtCO2 can be a sign of ROSC. What is ROSC? Remember, that is return of spontaneous circulation. So capnography is a valuable tool for both confirming correct placement of an airway. For instance, like an iGel. I know that's what a majority of my departments that I train use is the iGel, and gauging the quality of CPR. So how can an EMT and an EMR use capnography to monitor their progress during the resuscitation effort? So it's a pretty valuable tool to monitor the progress during the resuscitation efforts, especially in cases of cardiac arrest or respiratory failure. So capnography measures the concentration of carbon dioxide, which is what? Carbon dioxide is also known as CO2, in the exhaled air, providing real-time information about the patient's ventilation and circulation. So here's how the EMT and EMR can use capnography during resuscitation. Number one is assessing the effectiveness of chest compressions. So the end tidal CO2 is the amount of CO2 exhaled at the end of each breath. So during CPR, an increased end tidal CO2 is often a good indicator that chest compressions are effective and blood flow to the lungs is actually occurring. If the EtCO2 level rises above 10 to 20, it suggests that CPR is generally generating some circulation and oxygenation. However, decreased or absent end tidal CO2 is very low or zero. It may actually indicate that the chest compressions are not effective, they're not circulating the blood, or maybe the airway is obstructed. So indicating that ROSC, or the return of spontaneous circulation, is one of the most important uses of the capnography during the resuscitation is to monitor for ROSC, which refers to the spontaneous return of the heart's ability to pump blood. So remember, sudden increase in the end tidal CO2, if it's sudden or in a significant rise in it, it is a strong sign that ROSC has actually been received. So you'll be able to tell if you have capnography that this patient is maybe breathing on their own, so it would be adequate for you to stop and check to see if they are taking breaths on their own. So remember, the return of blood flow to the lungs leads to more effective removal of CO2, which is causing an increase in the end tidal CO2 readings. So this is often a more reliable sign than assessing a pulse, as pulse checks can sometimes be missed or delayed during the resuscitation. Stable end tidal CO2s, even in cases where ROSC has not been achieved, a stable or rising end tidal CO2 level, which is greater than 10, may indicate that CPR is ongoing and it's actually effective. Then guiding ventilations, end tidal CO2 levels can actually help you adjust their ventilation rate and volume during resuscitation. So if the end tidal CO2 levels are too low, what does that indicate? It indicates that you have inadequate ventilation. You can actually increase the rate or the volume of breaths delivered. So if the end tidal CO2 is too high, it may indicate hyperventilation, and you can adjust their breathing technique to avoid overventilating that patient. So the goal essentially is to achieve an end tidal CO2 in the range of 30 to 45 in a well-ventilated patient. So during CPR, the end tidal level below 10 often suggests, again, that what? It has ineffective CPR and possibly a very poor prognosis. So you want to also monitor for pulmonary embolism or any other complications. So remembering a drop or a sudden drop actually in end tidal CO2 could indicate that the patient has a pulmonary embolism, or maybe it's another complication such as an airway obstruction is actually occurring. So if the capnography shows a sharp decrease or sudden cessation of the CO2 output, you should consider the possibility that this patient does have a PE or other issues that could impair circulation and adjust their treatment accordingly. The other nice thing about it is it has a real-time feedback during airway management. It can provide, like I said, it'll provide that immediate feedback. So if you are using, or maybe you as an EMT are working on an ALS truck, you may see it used on an endotracheal tube or a supraglottic airway device like an iGel and so forth. So capnography can confirm the proper placement by showing a normal waveform and a stable end-tidal CO2 rating. So if that end-tidal CO2 level is absent or very low, it may indicate that the tube is not in the trachea. Okay. You should then recheck it, reposition the airway, and so forth. Make sure if it is with an ET tube, you are letting your paramedic partner or the advanced life support team member know that. It's also nice for tracking trends over time. So continuous capnography allows you to monitor trends over the course of the resuscitation. So rising trends in the end-tidal CO2 over time can actually indicate improved cardiac output and ventilation, suggesting that the patient may be responding positively to the treatment. A declining or flat end-tidal CO2 trend may signal deterioration, prompting you to reevaluate the approach and consider advanced interventions or adjustments. From a prognosis value, there's not a lot that from an EMS standpoint that you, especially rescue squad, that you're going to worry about too much, but low end-tidal CO2 levels early in resuscitation, particularly if they remain low despite adequate CPR, can be a poor prognosis sign. Some studies suggest that if that ET CO2 remains below 10 for an extended period of time during CPR, it may indicate a lower chance of successful resuscitation and survival. So again, the data helps guide the decisions whether to continue that resuscitative efforts and consider transitioning to palliative care, so on, so on. So key capnography waveform patterns. You have your normal waveform, which indicates proper ventilation and effective CPR. Then you have your flat or absent waveform that indicates no CO2 is being expelled, suggesting either inadequate chest compressions or an airway problem like an improper placement of an ET tube or supraglottic airway. And then the sudden increase in the end-tidal CO2 indicates potential ROSC or return of spontaneous circulation. And then the gradual decrease or plateau may suggest an ineffective CPR or a worsening prognosis or complication like possibly a pulmonary embolism. So in conclusion, with all of this, capnography provides you with real-time objective feedback on the effectiveness of the resuscitation efforts. So monitoring their end-tidal CO2 levels, you can assess the effectiveness of chest compressions, detect signs of ROSC, adjust your ventilations if needed, and identify potential complications early. This, in my opinion and a lot of people's, makes capnography a valuable tool for improving the chances of a successful outcome during cardiac arrest and other emergencies. Does that mean I'm telling you if you don't have it, go out and get it, go out and buy it? No, I'm telling you this is something you should look at maybe for the future if you have some extra dollars laying around. All right, next is treatment of cardiac dysrhythmias. So dysrhythmias are irregular heartbeats that can lead to cardiac arrest. Shockable rhythms are going to be VFib and VTach, where non-shockable rhythms are going to be asystole and PEA. Shockable rhythms require defibrillation with either an AED or you can use a manual defibrillator if you are trained to do so. Non-shockable rhythms require high-quality CPR and medications like epinephrine. So following the correct treatment protocols based on rhythm recognition is very important. And most of all, your own protocols, what you are allowed to do. So what are the first steps you should take when recognizing a shockable rhythm? So when you recognize a shockable rhythm, such as ventricular fibrillation or pulseless ventricular tachycardia during a cardiac arrest situation, they must act quickly and decisively. So the first steps are crucial for optimizing the chances of survival and ensuring effective treatment. So here's what you're going to start out by doing. Number one, you're going to verify that the rhythm is what it is and confirm the patient's condition and assess the patient. So ensure that the patient is unresponsive and not breathing or has an abnormal breathing pattern like agonal breathing. You want to check for a pulse, confirm that the patient is pulseless, as this is crucial as shockable rhythms, VFib or pulseless VTach require immediate defibrillation. So then you're going to assess the rhythm. So if you're using an automated external defibrillator, an AED, or maybe you're working on an ALS truck and you guys have manual defibrillators and your paramedic is going to be the one running the manual defibrillator, they need to confirm that the rhythm is shockable, either ventricular fibrillation or pulseless VTach. Your AED is going to know that for you. They're going to analyze it and it's going to tell you. So the AED will, again, advise when shock is necessary. If it says no shock advised, it's going to tell you to start CPR. For manual defibrillation, the EMT or EMR should identify the rhythm on the monitor screen. Now, granted, I know that most EMTs and EMRs are not trained to do this, so this is where your paramedic partner or advanced partner would come into play. Next thing you're going to do is you're going to call for backup and activate the resuscitation team, meaning maybe you need activate that EMS system, either the ALS truck, maybe a helicopter, or so forth, whatever your area agrees to do or whatever in your protocol. So if it's not done already, then again, call for additional help to assist with advanced interventions such as that innovation or medication administration. You're going to gather your equipment and ensure that the appropriate equipment is readily available and it's functioning, like your defibrillator, your airway management tools, and so forth. Then you're going to start high quality chest compressions. If not already performing CPR, you want to initiate that high quality chest compressions at that rate of 100 to 120 per minute and a depth of at least 2 inches or 5 centimeters for an adult patient. You want to make sure that you are ensuring full recoil of the chest between those compressions, avoiding leaning on the chest. When you're doing chest compressions, you want to minimize the interruptions. It should be a continuous with minimal interruptions, and they are very critical for maintaining that circulation to the heart, the vital organs, and especially during the time it takes to prepare that defibrillation. So years ago, they used to say when you're preparing that defib and putting those pads on, you should be, hands off and putting the AED on and then going back to compressions after it analyzes. However, it is now switched, and they're saying if you have 2 people, one should be continuing to do the compressions and the other one should be applying that AED onto the patient's chest. The only time you're going to stop the chest compressions is when the AED says that it's analyzing that heart rhythm. That's when you should stop touching. So you want to get the defibrillator ready for shock delivery. So whether using the AED or the manual defibrillator, ensure it is powered on and the pads are properly positioned on the patient's chest, typically one on the upper right side of the chest and the other on the lower left side. You want to clear that area before delivering the shock and make sure that no one is touching the patient, announcing clear loudly and ensure all personnel are clear of the patient to prevent any injury. Next, you're going to deliver the shock if indicated and follow the AED instructions. So again, if using an AED, follow the device's instructions. It will guide you through the shock delivery process. The AED will automatically analyze the rhythm and advise whether the shock is needed. For manual defibrillation, if using a manual defibrillator or with a team that is, deliver that shock at the appropriate energy level, typically starting at 200 joules for the biphasic defibrillators, higher for the monophasic devices, but again, that goes back to your protocols. Immediately resuming CPR after the shock is delivered, immediately resume, starting with the chest compressions. The pulse should only be performed briefly to confirm if the rhythm change has occurred. So typically CPR should continue for 2 minutes before reassessing that rhythm. Then you want to reassess the patient and monitor the rhythm. So after delivering the shock and performing that 2 minutes of high quality CPR, you're going to reassess the patient's rhythm using the defibrillator. And then if that rhythm is shockable, like the VFib or pulseless VTach, then another shock may be necessary. Continue your CPR and defibrillation cycles. So if the rhythm is still shockable, you're going to repeat that sequence of defibrillation and CPR until it says no shock advised. Typically, this cycle is continued with shock, then CPR for 2 minutes until you get ROSC back, which again, remember, ROSC is return of spontaneous circulation. It is achieved or typically advanced care is provided. Next, you're going to administer the medications if appropriate. Again, this would be when your ALS crew arrives on scene. They can give that epinephrine, typically, again, that 3 to 5 minutes during a cardiac arrest. Some protocols will say amiodarone or lidocaine. Now it's changing, so it really all depends on the year, who your medical director is, and the area that you're in. It's not just cut and dry anymore. Again, EMTs and EMRs are not going to be doing this, but they may be working with an ALS partner or an advanced partner that this would be good information. So first and foremost, ensuring that the rhythm is shockable. Again, VFib or VTAC, pulseless VTAC. The patient is pulseless. You're going to start chest compressions immediately. If it's already not doing so, if somebody's already not doing it, prepare for defibrillation and clear the patient, delivering that shock. Resume CPR right after the shock and continues the cycle until ROSC is achieved or ALS takes over. The quick identification of a shockable rhythm and early delivery of defibrillation combined with high quality CPR is critical for improving the chances of survival during a cardiac arrest. All right, on to the treatment of shockable rhythms. So the specific steps for managing shockable rhythms is first to recognize that the rhythm is VFib or VTAC. However, if you are a BLS crew, your AED is automatically going to look at the heart rhythm, analyze it, and then they're going to tell you. However, if you do work with an ALS crew, or if you have a monitor that you can see that, again, you should still be in the AED mode. However, you can still see it on the monitor as long as you are trained to know and understand what it is. So you first need to deliver that shock. So remember, early defibrillation is key. It also helps to restore that normal rhythm. So then you're going to continue with the high quality CPR after shock. Administer epi per protocols, as long as you're with an ALS crew. Continue monitoring for ROSC and early defibrillation, and timely administration of the medications are critical to their survival. So some things to ask is, why is it essential to continue CPR after defibrillation? So continuing CPR after defibrillation is essential because defibrillation alone does not guarantee that the heart will resume normal function or restore adequate circulation. So why is ongoing CPR critical after delivering a shock? Well, first, defibrillation restores that rhythm, not circulation. So defibrillation, or also known as shock, is used to reset the heart's electrical activity with the goal of converting ventricular fibrillation or pulseless ventricular tachycardia into a normal rhythm. However, while the shock may restore a normal rhythm, it does not restart the heart's mechanical pumping ability or immediately restore adequate blood circulation. So CPR, again, your chest compressions, continue to circulate that oxygenated blood to vital organs, particularly the brain and the heart, while the heart is still trying to regain its normal function. Next is preventing stagnation of blood flow, which that's where CPR helps to maintain that blood flow to those vital organs and even after defibrillation. So if CPR is stopped after a shock, the heart may not be able to pump enough blood on its own immediately afterwards. So without chest compressions, blood flow stagnates, depriving the organs, especially the brain, of the oxygen and the nutrients. So by continuing CPR, you're providing the necessary circulation to keep those organs viable until the heart can effectively pump on its own. Then you want to do, it's there to maximize the effects of defibrillation. So after a shock, it is possible for the heart to enter a brief period of asystole, or what's known as flatline, or pulseless electrical activity, PEA. So where the electrical rhythm may not yet be sufficient to generate an effective heartbeat. So continuing CPR ensures that the body still receives that blood flow, giving the heart time to recover from shock and start contracting effectively. So ongoing chest compressions also help the blood pressure up, allowing vital organs to receive oxygen and nutrients while the heart tries to recover. Then you've got improving the odds of the return of spontaneous circulation, or ROSC. So high quality CPR increases the likelihood of achieving ROSC, which what does ROSC stand for? It's return of spontaneous circulation. So high quality CPR increases that likelihood of achieving ROSC after shock. So studies have shown that consistent, effective CPR following defibrillation improves the chances of favorable outcome by maintaining perfusion to the heart and the brain. That's why continuing CPR for 2 minutes after each shock allows that heart time to respond to the shock and may increase the chances of ROSC, particularly when combined with the appropriate medications like epinephrine. That's why it's important for BLS crews to contact an ALS service, a helicopter, whatever it may be, to come out and do an intercept with them and transport the patient and being able to give them those additional medications. Then it's maximizing blood flow or blood oxygenation. So chest compressions during CPR help deliver that oxygenated blood to the heart and the brain. Even if defibrillation successfully converts the rhythm to something more stable, blood oxygenation is still crucial for the survival of tissues. So if CPR is stopped prematurely, blood flow and oxygen delivery to these organs stop, reducing the likelihood of recovery. Then you want to allow time for that drug administration. So in many cases, drugs like epinephrine or amiodarone are administered to improve the chances of survival during the defibrillation. CPR helps to circulate these drugs through the body, ensuring that they reach the heart and other organs more effectively. So essentially, in summary of everything we talked about, defibrillation is a critical first step in treating shockable rhythms like ventricular fibrillation or pulseless V-tach. But it only restores the electrical rhythm of the heart. CPR is still necessary to provide ongoing circulation, ensuring the oxygen delivery to the vital organs, and increases the chance of the heart recovering its ability to pump effectively. So continuing CPR after defibrillation maximizes the effectiveness of the shock and improves the chances of survival and recovery. Next, on to emergency medicine dispatch and cardiac arrest. So we have to remember that EMS dispatchers is an early intervention for cardiac arrest. They are the ones that are providing CPR instructions to bystanders even before EMRs, EMTs, paramedics arrive on scene. So dispatch ensures that rapid EMS activation and prepares the team with critical patient information. So early initiation of CPR by bystanders, guided by dispatch, can dramatically improve those outcomes of that patient. So how can we as EMS providers ensure coordination with dispatch to optimize that patient care? So first, ensuring effective communication between all of the EMS teams and dispatch is critical for optimizing that patient care, especially in time-sensitive situations like cardiac arrest, maybe traumas or medical emergencies. So here's some ways that EMS teams can improve coordination with dispatch. First, make sure that you are clear and timely on your communication, okay? Providing clear and concise and accurate information about the patient's condition, where the patient is found, any special needs. Maybe you need a boat, maybe you need a UTV with, something. Giving that information back to dispatch is going to then help them be able to communicate onto the transporting ambulance service that, hey, this patient is, out in a remote area. Maybe that's where fire departments need to come in to help with the extrication process. It's always important to use either the radio or digital communication effectively. Just remember, EMS team should ensure that you have reliable radios or digital communication systems with dispatch. If at all possible, they should also use real-time electronic data sharing to send updates. Now, this I know is fairly new, and in some smaller services, especially rescue squads, you don't have the funds for it. There's a big, huge integration system, so I wouldn't worry about this too terribly much, but for, larger services, this might be okay. So it would then, even like your monitors, your cardiac monitors, that you can hook up your 12 leads to be sent to, the hospital that patient is going to. That will give the hospital staff time to look at that 12 lead to say, hey, we want you to contact a helicopter and get this patient in a helicopter to, the cardiac center or wherever they decide that they want to send them. Next is providing accurate location and scene details. So you want to share your location information early. At that point, then dispatch can immediately begin routing resources. Maybe it's additional ambulances, maybe it's specialized units, maybe it's a helicopter, maybe it's fire, maybe it's hazmat, maybe it's who knows what it could be, but that gives them time to get more resources available to you. Or to the scene. So once the exact location is confirmed, if there is, some issue with the location, it can delay response times, especially in rural areas or complex, urban areas essentially. But, here we've got thousands of acres of land. Maybe it's a farmer and he's on his back north field to the west of County Highway 62. In that sense, where is that location? There's not a good address. There's not specific address. So that's why you want to, when you get on scene, you want to try to have the best and precise location so you can send that back to dispatch so they can let others know. You should also then describe the scene. So EMS teams should communicate details about the scene, like the patient's condition, any potential hazards, the need for specialized resources. Again, going back to the helicopter, law enforcement, for safety, fire departments, for extrication, so on. Dispatch can then relay this information to the incoming resources and prepare them accordingly. Again, early activation of resources is key. EMS teams should request these resources early, like ALS units, firefighters, fire departments, law enforcement. As you see the need, these things should be dispatched right away. Maybe it's a power line that's down and maybe it has nothing to do with, fire, law enforcement, or whatever else. Maybe it's a power company that needs to be called. Maybe you get out to the scene and you smell a gas leak and maybe the gas company needs to be called. So these are the different things that you need to be looking at. For example, in cases of cardiac arrest, EMS should request bystander CPR guide and advanced life support. Okay. So, I mean, if you have somebody on scene and you have the dispatcher on the phone, you can say, is that early CPR started yet? And if not, the dispatcher should encourage that patient to do that. Or not the patient, the bystander. So then it's also nice to pre-alert the receiving hospital. So dispatch can send information ahead of time to the receiving hospital, so the hospital staff are prepared to receive that patient immediately upon arrival. This can include trauma alerts, stroke alerts, STEMIs, just different alerts that will help them. If you as a rescue squad know that this patient is going to be transferred to a specific hospital, if you have an extra set of hands, you can radio to your ambulance, the transporting ambulance, and tell them what's going on. You can also, send that on to dispatch, and then they can let them know. Or, you call the hospital directly. But most of the time in a rescue squad situation, I'd give the report right to the transporting ambulance and let them figure it out from there. Real-time information sharing. So patient information and share that stuff is key. So dispatch and EMS teams should ensure that all relevant patient information is shared in real time. Things like the patient's vitals, changes in their condition, loss of a pulse, interventions that are performed. Maybe you started CPR, maybe you administered medication. It really depends on your department, on your, what's going on, but I would definitely, especially if you're working a cardiac arrest and you finally have a second person or a third person that shows up that can contact the transporting ambulance or dispatch to relay the information, especially if you're working from 2 different counties. You can say, this is what we got going on now, CPR is in progress, the patient has no pulse, yada, whatever your report is. And then, make sure that your transporting ambulance service knows that. Monitoring and updating progress. So provide regular updates to dispatch. Again, I don't really see this necessarily in our area. However, there are some departments, in the metro areas that do this, but I don't foresee it so often here. However, if you have safety issues, if something drastic has changed, that is when you should update, dispatch, so they know that you're safe. How about reporting any delays or obstacles? So if there's any delays due to traffic, weather, logistical issues like, being stuck out in the middle of a cornfield, or maybe you're in the middle of a side-by-side trail, or, four-wheeling trail, or whatever. That's the information. And then collaborate on treatment and transport decisions. So input from dispatch. Maybe they know that one hospital is full capacity, so you can't transport the patient there. You have to transport them somewhere else. This doesn't happen very often, especially in an emergency situation, but it can, especially if they know that there's a mass incident happening in that area at the same time. So, the other side of it is dispatch can help call the hospital if you don't have time. Maybe you don't have enough hands, or you don't have enough people, or whatever the deal may be. Maybe they can call ahead and just let them know this is what you got. Maybe it's a stroke, maybe it's a trauma, and just get them to be aware of what's happening. Again, getting back to, basically a clear handover of information. So, dispatch gives the hospital stuff. Now you're en route to the hospital, or maybe the transporting ambulance says, hey, we don't have time to call into the hospital. Can you please call them, give them a quick update or a report, tell them we're busy. We'll try to get them a report before we get to the hospital. That's adequate. I would ask the ambulance service, that's transporting, if that's what they want you to do. Sometimes they're like, nope, don't worry about it. We'll take care of it ourselves. And then it's always good to do like a post-call review, get feedback. Maybe it's a debrief type situation, and just having that continuous improvement. So after the call, both EMS teams, maybe dispatch can be included in it, but just a quick debrief to evaluate the effectiveness of the response. This should not happen on every single call, but maybe it's a bad trauma call where there's lots of units, there's lots of people involved, there's dispatch involved, there's all sorts of things happening, and basically doing a quick debrief of, hey, what did we do wrong from the scene side of things to improve the next time? Or maybe you can contact the dispatch supervisor and say, hey, the next time can we maybe look at the dispatchers doing X, Y, and Z? But remember, you both have separate protocols, so that's where sometimes those protocols overlap, and then dispatch is doing what their protocol says, you're doing what your protocol says, but there's an overlap or whatever in what you guys can do together. So just remember, effective coordination between EMS teams and dispatch is essential for delivering the best patient care possible. So by maintaining that clear communication, sharing real-time information, activating resources early, and adhering to standard protocols, both dispatch and EMS teams can work together, fairly seamlessly most of the time. So this ensures that the patient receives timely, efficient care, whether in the field or during transport to the hospital. All right, next is infection control practices in cardiac arrest. So infection control practices during resuscitation efforts include PPE, such as gloves, masks, and eye protection, which should essentially be worn always, okay? Eye protection, masks, I know they don't always get worn, however, they should be, just for your own protection. You want to avoid the direct mouth-to-mouth ventilation, so you want to use that barrier device or a BVM if possible. So wearing PPE helps protect both you and the patient from any cross-contamination. So what other infection control measures might be critical during a cardiac arrest? So any infection control during a cardiac arrest response is very critical to ensuring safety of both the patient and the EMS responders. So by using that appropriate PPE, practicing proper hygiene, following strict protocols for disinfection, even if you are a rescue squad that does not transport the patient, you should still disinfect your equipment and you should wipe down the truck, especially if the bag was taken into the home or into a facility. It should still be wiped down, on the bottom or wherever, just to help with that disinfection process. You want to ensure clear communication about the potential risks of infection. So if you know when you get on scene that this patient has tuberculosis, you want to clearly let everybody else know that that's what's happening with this patient. EMS teams can minimize the risk of cross-contamination and maintain high standard of care while protecting themselves and others from the potential infection. Next, we're going to talk about pediatric cardiac arrest. So the unique aspects of pediatric cardiac arrest are often caused by respiratory failure or hypoxia rather than primarily cardiac issues. Your pediatric protocols are going to differ, so check the compression depth, the rate, and the AED use for your specific protocols. And just remember that early CPR and rapid defibrillation in children, just as in adults, is important. So what are some of the key differences in treating pediatric versus adult cardiac arrest? So treating pediatric cardiac arrest differs from treating an adult cardiac arrest in several ways due to the differences in the physiology and the underlying causes. And it could be even the treatment protocols. So while the core principles of basic life support and advanced cardiac life support apply to both, there are important distinctions in the approach and the management side of things. So one is etiology and causes of cardiac arrest. So remember, in pediatric patients, pediatric cardiac arrest is more likely caused by respiratory distress or failure, possibly asthma, choking, or an infection like pneumonia, leading to hypoxia. So drowning and trauma are also some common causes of pediatric arrest. So that's another thing to think about. Cardiac arrest in children is often secondary to a prolonged period of inadequate oxygenation. Next, with compressions and depths, the rate for infants and children, the depth of compressions varies depending on the child's size. So if you're talking about an infant under 1 year of age, compression should be about 1.5 inches or 4 centimeters deep, or 1/3 the depth of the chest. So in children age 1 to 8, compression should be around 2 inches deep or 5 centimeters. For both infants and children, the compression rate is the same as the adults, which is that 100 to 120 compressions per minute. As far as compression to ventilation ratio in pediatric CPR, the ratio for one rescuer is 30 compressions, 2 breaths, which is the same as the adults. But for 2 rescuer, it changes to 15 compressions, 2 breaths for the infants and children under the age of 8. So this is due to the greater importance of providing adequate ventilation in pediatric patients who may have significant respiratory causes of arrest. Next is airway management. So pediatric airways are more prone to obstruction, so managing the airway is even more critical. In infants and small children, the airway is smaller and more flexible, so you need to make sure that you use the right sized equipment and be cautious when using the bag valve mask because and when you're doing ventilation to avoid overinflating the lungs. Infants and toddlers are particularly prone to airway obstruction due to their smaller airways, so using that head tilt chin lift technique for opening the airway and delivering gentle breaths is crucial. Oxygen delivery is also more critical in pediatric patients as they are more sensitive to hypoxia. With defibrillation and the use of AEDs, so most BLS crews are carrying an automated external defibrillator with pediatric capabilities or pediatric pads, which should be used for children less than 8 years of age. So for any child older than 8, adult settings can be used, so those would be switched over to the adult pad. The decision to defibrillate a pediatric case often depends on the presence of a shockable rhythm, such as VFib or pulseless ventricular tachycardia. But pediatric patients more commonly have asystole or pulseless electrical activity in which defibrillation is generally not effective. Pediatric doses of medication are weighed on the base, are weight-based rather than not. So the doses are much smaller. So for example, epinephrine for pediatric patient is typically administered at 0.01 milligrams per kilogram every 3 to 5 minutes during a cardiac arrest or a code. Amiodarone and lidocaine are also used, but may be given at pediatric doses. Again, the dosing, make sure you always check your local protocols because this could be different. It is crucial that medication doses and administration are calculated precisely based on the child's weight and age to avoid overdosing or possibly even underdosing. As far as post-resuscitation in pediatric patients go, post-resuscitation care in children is similar but with specific attention to their age and size. So pediatric patients are more sensitive to fluid shifts and hypothermia, so careful fluid management and temperature regulation are also critical. Pediatrics often require careful neurologic monitoring as an anoxic brain injury is a significant concern in children who have experienced a prolonged arrest. And then last is going to be your psychological and emotional pediatrics. So the emotional toll on the parents and caregivers can become very overwhelming during a pediatric cardiac arrest. So you as medical personnel should communicate effectively with the family, offering reassurance and compassion while also providing clear updates on the patient's status. Essentially, don't lie to them. If you are doing chest compressions and you're keeping their blood flowing, you need to tell them that. If you have an airway in them and you're doing manual ventilations, you need to tell them that. Don't give them any false hope because that is tougher on the family in the end. So essentially, a quick rundown, the main differences between treating pediatric and adult cardiac arrest stem from the causes of the arrest. So the physiology of the patients and the treatment protocols. So in pediatric patients, you want to focus often on the respiratory support, smaller drug doses, and tailored airway management. The compression depth, defibrillation energy, and the medication doses all differ based on the child's age and weight. So while the core principles of timely CPR, defibrillation, and early medication administration are similar, pediatric patients require more precise and age-appropriate interventions. All right, now to post-ROSC treatment. So remember, ROSC is the return of spontaneous circulation. This does not mean that the patient is out of danger. The critical steps in post-ROSC care optimize ventilation and oxygenation. So you want to control the body temperature, therapeutic hypothermia when indicated. Again, if this is not in your protocol, this is not something you should do. Prepare for immediate transport to a facility capable of post-resuscitation care, especially one that does have a cath lab availability. So why is controlling the patient's temperature important after ROSC? So controlling their temperature after ROSC is essential because temperature management plays a critical role in neuroprotection, minimizing organ damage, and improving overall survival outcomes after a cardiac arrest. So here's why temperature control is so important in your post-cardiac arrest care. So first is the neuroprotection and brain function, hypoxic ischemic injuries. So after cardiac arrest, the brain is particularly vulnerable to injury due to the lack of oxygen and blood flow. So when circulation is restored, reperfusion injury occurs, which can lead to further damage to brain cells and tissues. So in therapeutic hypothermia, again, if your protocol allows, it's inducing mild hypothermia, which is cooling the body to around 32 to 36 degrees Celsius or 89.6 to 96.8 degrees Fahrenheit, has been shown to reduce that cerebral metabolic demand, decreasing inflammation and minimizing brain edema. So cooling the patient's body after ROSC helps protect the brain by slowing down the cellular process that leads to damage following that reperfusion injury. So this can improve neurological outcomes and reduce the risk of long-term disability or death. Next, reduced brain injury. So several clinical studies, particularly after out-of-hospital cardiac arrest, has demonstrated that targeted temperatures can improve survival with good neurologic function, especially in cases of cardiac arrest due to ventricular fibrillation or pulseless ventricular tachycardia. Then you've got prevention of secondary injury and metabolic demand. So after ROSC, the brain is in a state of metabolic imbalance due to the shock it experienced. So hypothermia helps lower the systemic metabolic demand and oxygen consumption, which is crucial when the body's ability to deliver oxygen and nutrients to the tissues still may be compromised. Then you've got the reduction of inflammation. So hyperthermia, after ROSC is associated with increased inflammation, which can exacerbate tissue injury. So keeping the body cool helps suppress the inflammation cascade and can reduce the severity of damage to organs, particularly in the brain and the heart. So prevention of organ dysfunction is another one, which managing the body temperature can also help prevent multi-organ dysfunction. Hyperthermia is linked to worsening kidney function, liver failure, and other organ systems after resuscitation. So your temperature regulation can help improve the function of these organs and increase the chances of survival. Then you've got the improved survival rates, better neurological outcomes. So by cooling patients after ROSC, it has shown to improve the survival with good neurological outcomes and the ability to return to a normal cognitive function and quality of life after. So without temperature control, there is a higher likelihood of severe neurological impairment or possibly even death. So how about optimized perfusion and hemodynamics? So with that, cooling can help stabilize the circulatory system and blood pressure, reducing the risk of hemodynamic instability after ROSC, which then helps to prevent arrhythmias, which are common during the post-resuscitation period. So temperature guidelines for post-ROSC care, targeted temperature management, again, going back to your local protocols, but guidelines are recommending cooling to that 32 to 36 degrees Celsius for at least 24 hours in patients who have not regained consciousness after ROSC. This is done through controlled cooling techniques such as cold saline infusions, cooling blankets, or intravenous cooling devices. So your biggest thing is you want to avoid the fever. So if cooling is not implemented, keeping the patient's temperature below that 99.5 degrees Fahrenheit is important. So fever in a post-ROSC period can lead to worsened neurological outcomes, and hence the antipyretics or fever-reducing medications and other interventions may be used to control the patient's temperature. So fever as a complicating factor is increasing the mortality and morbidity. Some studies have shown that fever in the post-resuscitation period is associated with higher mortality rates and worse neurological outcomes. So fever may increase brain injury and worsen the inflammatory response, which is why controlling temperature to prevent it from rising above normal is critical. So what's the impact on recovery? So a fever can exacerbate that metabolic demand, increasing the brain damage and impair the body's ability to recover. Thus, cooling therapy is a key strategy to optimizing the recovery and their survival after ROSC. So with all that being said, controlling the temperature after ROSC is crucial for reducing neurological injury, minimizing organ dysfunction, and improving overall survival rates. So the practice of targeted temperature management by cooling the patients to around that 32 to 36 degrees Celsius helps protect the brain, reducing the inflammation and optimizing systemic function, which are all vital for maximizing the recovery following a cardiac arrest. So without temperature control, there is a risk of further injury to the brain and other organs. So this can potentially lead to worse outcomes or even death. So therefore, temperature management is considered a critical component of post-cardiac arrest care. Again, if your protocol allows it. Next is pre-hospital predictors of survival and mortality. Pre-hospital predictors of survival include early CPR and defibrillation. This will increase the likelihood of the patient's survival. If you have a witnessed arrest and a short time to defibrillation, those are key factors. The patient's age, comorbidities, and the cause of the arrest are also influence on that outcome. The predictors of mortality are going to be your CPR and non-shockable rhythms. So what are the most significant predictors of survival in that out-of-hospital cardiac arrest? So first, the prognosis of out-of-hospital cardiac arrest is influenced by several factors that can significantly impact the rates and the survival rates and the neurological outcomes. So the most significant predictors of survival in out-of-hospital cardiac arrest is first going to be early bystander CPR. So that immediate initiation of CPR by a bystander is one of the most important factors of influencing survival. So high quality, uninterrupted chest compressions improve that blood circulation to those vital organs, especially the brain, and it can maintain a higher chance of return of spontaneous circulation. Next is going to be your early defibrillation, which is crucial for patients in shockable rhythms like VFib or pulseless V-tach. The earlier the automated external defibrillator or AED is used, the higher the likelihood of survival. Then you have the response time and quality of EMS care. So from the time to the first shock or the time to ROSC, which is that return of spontaneous circulation, that plays a critical role in that outcome of that out-of-hospital cardiac arrest. So the shorter the response time of emergency personnel, the better the survival prospects are. Then you want to get your advanced life support in there because they're the ones that are going to be able to give them medications like the epinephrine, amiodarone, lidocaine, maybe put an advanced airway in. So those are just some other key factors for improving the chances of survival after that initial resuscitation. Next is the initial rhythm. So what is that patient's initial cardiac rhythm at the time of collapse? Knowing that is going to be a strong predictor of their survival. So shockable rhythms like ventricular fibrillation or pulseless ventricular tachycardia offer a much higher chance of survival compared to a non-shockable rhythm like asystole or the pulseless electrical activity. So shockable rhythms have a higher conversion rate to spontaneous circulation when defibrillation is performed early. And then you have the age of the patient. So the younger the patients generally have a better survival outcome compared to older individuals after that out-of-hospital cardiac arrest. So the older age is associated with increased comorbidities, decreased physiology, it's just poor neurologic outcomes after that resuscitation, especially if they are in cardiac arrest for a prolonged time. Next is going to be your witnessed arrest. So a witnessed arrest, like we talked about, has better outcome because bystander CPR can be started immediately. If you have the use of an AED, it's more likely to occur fairly quick, actually, after a cardiac arrest. So unwitnessed arrests, where the event occurs in a location or a situation where it's not, immediately noticed, have a lower survival rate because there is such a delay in CPR and defibrillation, and you don't know how long they've been down. Next is, cardiac arrest. So the cause of the cardiac arrest is another important determination. So essentially what you're looking for is what caused it. Was it a myocardial infarction? Was it arrhythmias? Typically better outcomes if defibrillation is provided early. So non-cardiac causes such as trauma, drowning, drug overdose, those may be more complex outcomes depending on the severity and the time to the treatment. So arrests that are caused by hypoxia, such as those from respiratory failure, maybe drowning, may have a better survival chance due to the potential of reversal of those underlying causes, like airway management, getting them oxygen. Then you have, were you guys on scene already and you actually witnessed this patient go into cardiac arrest? If it is witnessed by, EMS, the chances of receiving high quality immediate intervention, such as CPR, defibrillation, an advanced airway or a supraglottic airway, are significantly increasing and leading to better survival outcomes. Okay. Next, you have the post-resuscitation care. So post-cardiac arrest care plays an important role in survival of the neurological outcomes. So this includes targeted temperature management. We've talked about this. Again, if this is not in your protocol, you can just ignore this section, but it's good information to know. So the targeted temperature management is to induce controlled hypothermia and optimize brain recovery, as well as optimal hemodynamic support, adequate oxygenation, and then ventilation. And then, of course, rapid transport to a specialized cardiac arrest center with the capabilities of PCI or angioplasty, which then improves those survival rates. Then you got your pre-existing health conditions, so your comorbidities such as diabetes, CHF, COPD, chronic heart disease, hypertension, renal failure. All of these generally reduce the chances of survival of these patients. So patients without significant comorbidities or those with relatively good baseline health may have a better chance of recovery after a cardiac arrest. So to have that good baseline function status, so basically what I'm saying here is that the patient's overall health is good prior to the arrest, it is, strongly correlated with better post-arrest recovery and neurological outcomes. So the worse the patient is prior to the arrest, the less chance of survival they have. The better health they're in, the better chance of survival. And again, this is getting a little bit deeper into, cardiac information, but again, knowing it and understanding it is probably beneficial to you guys as responders. But the initial blood gas and lactate levels is, in the blood gas values, particularly the lactate levels, are important indicators of the severity of the cardiac arrest and the patient's overall prognosis. Higher lactate levels, especially if they don't decrease after ROSC, can indicate severe tissue hypoxia and poor chance of survival. So arterial blood gas analysis can actually provide insights into oxygenation, acid-base status, and the presence of metabolic derangements, all of which can help predict their outcome. Again, you guys don't do this pre-hospitally normally, however, they do it in the hospital, and if you've ever heard of it, that's why it's always good to know and understand a little bit farther in depth from what your level is. Next is duration of the cardiac arrest. So what is their downtime? So the duration of the cardiac arrest or the amount of time that the patient has been without a pulse is one of the most critical factors for survival. So the shorter the downtime, typically anything less than 5 minutes, greatly improves their survival rates and the neurological outcomes. After a prolonged downtime, the chances of reversing brain injury and achieving a favorable neurological outcome dramatically decreases, even with successful return of spontaneous circulation. And then the last one is location of the cardiac arrest. So public places or areas with easy access to bystanders, maybe they have an AED, increases the likelihood of receiving immediate bystander CPR and defibrillation, which then in turn can improve survival outcomes. Home arrests or arrests that occur in a private space tend to have more poor outcomes due to the delay in recognition of the arrest and lack of immediate intervention. So if the patient happens to be home alone, the spouse or kids or whomever come over, hour or two later, the patient's already probably deceased, or if they do have any chance of survival, it's very probably pretty slim. So remembering that the most significant predictors of survival in out-of-hospital cardiac arrest include early bystander CPR, early defibrillation, the initial cardiac rhythm, the response time of EMS, the etiology of the arrest, the age and the health status of the patient, and the duration of the cardiac arrest itself. Post-resuscitation care, including temperature management if your protocol allows, the factors such as location of the arrest and bystander intervention can significantly impact the likelihood of survival and recovery, especially in terms of neurologic functions. All right, we made it. Here we are. So to the conclusion and the key takeaways. So first, remember, early recognition of cardiac arrest and high-quality CPR significantly improve that survival rate. Proper treatment of dysrhythmias, infection control, pediatric care, they're all vital components. Always follow your protocols and ensure continuous training for competency. You want to make sure that you're reviewing the key skills for the cardiac arrest management regularly to stay proficient. I know that CPR is only required every 2 years. However, there's advanced airways, there's medication, there's doses, there's all sorts of stuff depending on your level of care from EMR, EMT, paramedic, advanced, whatever you may be. Making sure that you are not just doing CPR refresher every 2 years, because you will not be proficient with that. All right. If you have any questions, please let me know.